Good morning, Mr Dunlop.
Morning, my lord. The first witness this morning is Mrs Holliday, and for the benefit of the recording, the witness reference number is SCI WT 0534, and as usual, the 5 zeros and the 1.
Thank you. Good morning, Mrs Holliday.
Good morning, my lord.
Now, when you're ready, Mr Dunlop.
Thank you, my lord. Good morning, Mrs Holliday.
Good morning,
If I could firstly remind you, just when you're giving your evidence, not to name any individuals.
Okay.
You've provided a statement to the inquiry, and we have that in front of us, and we see your full name and position within the Greater Glasgow and Clyde Health Board in paragraph 1. We also see in the first 4 paragraphs of the introduction that you're a registered nurse and a health visitor. Is that correct?
Yes.
And we also see that you've held various positions within Unite the Union since 2018. I think that's correct, is it?
Yes.
Thank you. And under the paragraphs headed Overview, and we find those at 5 to 13, you explain that health visitors are responsible for children from birth until school age, and that you provide support in relation to child development and health. And am I correct that your particular specialism is children from newborn children up to the age of 2?
Yes, in family nurse partnership, it's from pregnancy until the child is 2.
Okay, and when you say family, I appreciate you changed jobs in late 2021.
Yes.
Prior to that, when you were in the post at the outset of the pandemic, up to you changing your position in late 2021, was it children of a particular age that you were dealing with?
I was a health visitor team lead then, so that was children from birth until age 5 or entry to school.
Okay, thank you. And you explain at paragraph 9 of your statement that before the pandemic, health visitor services were done in person and mainly with the child at the family home in order to assess the child in their own environment. And just to give us an idea of how many different homes a health visitor might be in a particular week or month, can you give me, I know there's no such thing as an average day and there's no such thing as an average child, but how many children would a full-time health visitor see in an average day? If you
They may see 3, 4, 5 families in a day. It would depend on what was happening in the caseload. Caseloads can obviously sort of peak and trough at different times, and obviously there's a significant amount of record keeping that goes along with each visit. But the average used to be about 250 families for a full-time health visitor, but with the...
In a year, sorry?
250 on a caseload.
Oh, sorry.
No, sorry, in a full caseload to manage. But that's variable now with the uplift in health visitors over a few years, so it can vary from maybe round about 100, 120 on a caseload if you're in a very disadvantaged area, to maybe up to 350 in a more affluent area.
And just to get an idea of, you're not obviously going to see the same families every day.
No.
How on average, and again, I appreciate there'll be more vulnerable children you might need to see more often.
Yes.
There might be some that are developing that you don't need to see. But on average, would you see a child once a year?
No, and the Universal Pathway for Health Visiting has 11 contacts between birth and preschool for every child as a minimum, and most of them, about 8 of them, occur in the first year of the child's life.
Okay. So during some years, could a health visitor be in 100 different homes over the space?
I'm not sure, but I would imagine it might be it might not be dissimilar to that.
You tell us at paragraph 17 of your statement that since the pandemic, the number of healthcare visitors is reducing. And I'm just wondering if that's related to COVID in any way. Can you explain why the numbers are reducing?
I don't think it's. I think the statement should say health visitors rather than healthcare visitors.
I'm sure it does.
My apologies for that. I don't think it's particularly to do with the pandemic. I think it's to do with budget decisions. We had an uplift in health visitors a few years ago in order to be able to support families to the level that we were talking about there, that 11 minimum mandatory contacts. And as a result of these sort of changes, health visitors were given an upgrade in their banding. They went from a band 6 to a band 7. Scottish Government, my understanding, is still funding us at band 6, and therefore HSCPs are staffing to that level and not to the level of the need that's required.
Okay. At the outbreak of the pandemic, I understand from reading your statement that it's in most visits were, as we said, in a child's home. What happened immediately at the beginning of the pandemic? Did that continue, or was it done remotely? Can you tell us what was?
At the very beginning, there was a business as usual message that went out that caused staff a bit of stress and anxiety, because although these visits and the assessments that come with them are useful, you wouldn't necessarily say that they were a life or death, thing in a pandemic. So staff wanted, I think, to naturally reduce down to sort of essential visits only. And that did happen, but it took a number of weeks for that guidance to sort of be produced. So I think staff felt that they were taking what would have been a common sense or logical approach, and then we were told for for a few weeks it was business as usual, and that was causing staff some stress.
So for a number of weeks, I don't want to pin you down, but can you remember how many weeks or how many months?
It would be weeks rather than months. I don't think I could say how long, but it would have been the first few weeks rather than months.
So during that period, health visitors were still going to family homes? They
were still going to family homes. I mean, certainly throughout the pandemic, we would certainly wanted to have seen the children that we considered to be, needed to be seen essentially. So things like brand new babies would have to be seen. Children who had high levels of vulnerability or were through child protection procedures would be wanted to be seen. Other contacts, we felt could be either paused or done remotely, depending on the needs and the circumstances for the family and the child.
When we talk of newborn babies, I presume most newborn babies are born in hospitals. Does that mean that the health visitors were going into homes where essentially the parents had just essentially come out of hospital?
The health visitor takes over from the midwife from day 10.
Right. From day 10 then?
Yes.
If I look at day 10.
From day 10 to 14, the newborn visit should be carried out.
During that initial period at the outset of the pandemic, when it was, I think the phrase was business as usual, was there, and I appreciate, we know from your statement that I think you managed a team of 18 health visitors.
Yes.
In terms of, did sickness absence increase during that period?
No, certainly not in the team I was managing at the time. It didn't. We were pretty well staffed. We had some staff that had to either shield or it was, they were then getting assessed about whether they could carry on doing face-to-face visits. And of course, that was one team in a range of services, but I don't overly remember a high level of sickness absence at that time. It might have been that we had some staff shielding, and we might have had some pregnant staff, and they were advised at a certain point in pregnancy to go and work at home. But we didn't really get high levels of sickness absence, I would say, until 2021. That year was when we started to get kind of chronic sickness absence.
Well, since we're just talking about it, and we'll come back to 2020, but I noticed you said at that time, we were talking at the beginning of the pandemic. So what happened in 2021?
I'm not entirely sure what happened. Some people, I think, took the opportunity once that sort of immediate part of the pandemic was over to potentially retire. Some staff retired, and other staff, sometimes reduced their hours, or people went off. I think people were finding work-related stress quite significant. It feels like the pace of the work has really escalated. The complexity of families has escalated since the pandemic, and there's not really been the reinvestment back into health visiting that allows you to support the work that you'd want to do.
We're particularly interested in, I suppose, COVID-related, not necessarily illnesses, but COVID-related absences, which could be mental health, or it could be COVID or long COVID. was there an increase in any COVID-related absences during that period in 2021?
There would have been some people, I can't speak for my team, there wasn't anybody in the team I managed that had that, but there was people off with on COVID special leave, I think, throughout the pandemic. We certainly had people that would contract COVID and would maybe have 10 days isolation, and their workload would have to be managed. And we had then other people that were off for other sort of related, other illnesses. So I don't remember a lot of COVID-related, long COVID-related absence.
Not necessarily long COVID, I was just really interested in whether it was COVID-related absences.
We certainly had, I think most people in the team eventually had COVID, so that would have required 10 days minimum of isolation at the time as the guidance.
And you say most of them, and I appreciate it's difficult to know when we're in supermarkets, on buses and so forth, but do you know if they were occupationally...
I don't know.
Don't know, okay. If we could look at your statement again, and I want to look at the challenges faced by health visitors in 2020 caused by the pandemic. Now, you mention at paragraph 25 of your statement that there was a lot of confusion around the use of the term essential workers and whether that would apply to health visitors, given that, and I think you identify that the service is provided during normal working hours and is not an emergency service. Was anything that you're aware of done by either your employers or perhaps the union to clarify whether health visitors were essential workers?
I'm not sure what happened at sort of higher levels of the union. We certainly got guidance that initially there was talk that health visitors might be redeployed, or a good percentage of the staff would be redeployed into other nursing roles. However, we did get guidance after a few weeks that we were to continue to try and see these children, and that these children would be, or visits to those children would be there was a level of being essential for that. So there wasn't the sort of high level of redeployment that was first anticipated.
In terms of just the term essential workers, given that I think you identified that there was a confusion over whether or not you fell under the category of essential workers, did that cause any particular difficulties in itself?
I think there was certainly some stress and difficulties about what that would mean for the staff, because health visitors... In
what respect? Sorry, can I...
So health visitors have obviously a unique skill set, but they're not necessarily... they felt anxious maybe about going back into a ward environment where, that nursing skill has been sort of removed over many years working in community in a service that's about promoting health and well-being. So there was a bit of worry about what would we be expected to do. But also there was the stress of feeling that some visits to families were not an absolute essential as part of in the middle of a pandemic, and the organisation sort of giving a message of business as usual also was causing people were worried they would take COVID into families. They were worried about bringing COVID back into their own family, all the kind of things that people were worried about at the beginning of that year.
Dealing with that point, and we'll come on to PPE that the health visitors had in due course, but I'm just interested in the families at the moment that were being visited. Were they, when a health visitor went into the house, were the family wearing masks or gloves?
No, I don't think so, although I think there was a mixed response. Some families didn't want the health visitor to come so that the visit could be offered, and they would decline the visit. And I know health visitors sometimes saw children through the window of the house, or they handed the scales in the garden, and then as the weather was quite nice that year, some of the visits were done, outside in the gardens. There was also some families, of course, were pleased to have contact from the health visitor because their normal social supports had reduced. So it was very mixed. Some families were quite set against, and some families were very welcoming, and there would be a personal choice about whether they would want to wear a mask in the house or not.
Was that in itself of concern to health visitors? I mean, obviously, the health board can impose rules upon health visitors. You're required to wear masks or so forth, but am I correct that you couldn't impose that upon families?
Yes, I think what worried people more was when there wasn't the ability to sort of manage who was in the visit. So we tried to encourage only to have one parent there, so that we could socially distance in the houses. And if families then had a number of people visiting, that certainly caused the health visitors a bit of personal sort of stress. When we didn't have PPE, the visits, going into visits, certainly was more, they found that more stressful. But I think they got some reassurance when we did get some PPE. And then if we did also, as time went on, we were able to ask about COVID, and if anybody had COVID, we could postpone the visit, and that helped when that guidance came. Latterly, people sort of said, if they needed to see the child, they went in with a mask, even if COVID was in the house. But generally, people postponed the visits and rearranged them for the 10 days after. So we had those abilities to be able to, if you like, sort of remove ourselves a little from anybody who was acutely unwell. But staff would be anxious if they had asked and people said no, they were fine, and then during the visit said, oh, we've all had COVID, or they're off because we've got COVID.
If staff were anxious, what could they do about it?
There was a bit of guidance around trying to shorten your visit. Not necessarily weighing the baby if you didn't need to weigh the baby, but generally that postponing the visit, or if there wasn't a level of high levels of risk or vulnerability, then moving the visit to a telephone or a remote through Attend Anywhere.
And you say moving the visit to remote or telephone. You identify in paragraph 28 of your statement that face-to-face visits were postponed. I think you say for a very short period of time. When was that period of time that face-to-face visits were postponed? So
I suppose the key thing is nobody. There was never a time where we didn't visit face-to-face. Right. We always visited those ones that I talked about that would be essential. So a brand new baby would always have had a face-to-face contact. Any children that were under child protection procedures would have had face-to-face contact. We reduced down the number of routine visits that we would offer, and that's where some of them were postponed. So we stopped doing some of the other pathway visits that weren't necessarily as critical.
And when postponed to me suggests that they didn't take place. Were
Yes.
they postponed or were they done remotely?
A mixture of both. Some people who were working at home carried on supporting families through telephone or Attend Anywhere contacts. Sometimes they would agree with colleagues, they would do a lot of that bit, and then the colleague would go out with the scales and weigh the baby, measure the baby, and finish off the assessment that way.
Now, if you're normally in a kind of an ideal world carrying out the health visit in person, that suggests there's a benefit to doing it in person. What particular disadvantages are there when you're assessing a child's development or health doing it remotely? Excuse me.
It's not the same. You don't get the same sense of what's going on for the child as you do when you're in their own home. When you're in their own home, that assessment is a very, I suppose, organic might be the word I would use. You can see it happening in real time. The child's comfortable in their home environment. You're also able to kind of explore sensitive topics, knowing that you're having a conversation with one person. So there would have been things that health visitors would routinely explore, things like gender-based violence, that they wouldn't have been able to be comfortable exploring that remotely when you don't know who else is in the room or part of that visit. When I should say, Mr. Donald, when I said that we were, I did say in my statement, we were back to kind of virtually all pathway visits again by the summer of 2020, and that was ahead, in Glasgow, that was ahead of the guidance that was issued from Scottish Government. They were still suggesting that some of the visits could be remote.
And when you say pathway visits, just for the benefit of us, what do you mean by pathway?
The universal pathway for health visiting, it's a standard that's the 11 contacts that are minimum for every family.
Thank you. And moving on to paragraph 30 of your statement, you say at the outset of the pandemic there was a lack of guidance from the Scottish Government and the health boards were waiting on that guidance. What type of guidance was it? What information in that guidance was being awaited?
So I suppose the initial sense was, why are we not able to go work at home for our administration purposes, not for obviously all our contacts, but for our documentation and our written assessment work and our administration processes. We had remote technology, why were we not able to do that? And then later on, some guidance about, who was going to be expected to be seen in terms of essential visits and who wasn't. If I could go back to my earlier point about your point about the impact when there's a lack of continuity, and the remote working did that, but the absence rate since the pandemic has had a huge impact on the ability to build a relationship with one health visitor to a family because of the absence.
And when you say the absence of the health visitor carrying out an in-person visit?
Yeah, but the health visitors, the level of absence means that your caseload is having to be covered by other staff, and they're dropping into visits, but they're not got the longevity of that continuous relationship.
Sorry, so that's other people having to step into the shoes of other people's caseloads, if you like? Yes.
So the guidance was initially about, being able to go work at home, and then also about there was also guidance about who were the staff who were to continue to work in the office or work face to face, and who were the staff that were to perhaps shield or be, if they weren't shielding, they were certainly advised because of their conditions to work at home, and also who was to be seen and what visits were to be done and what visits were not to be done or couldn't be done, didn't need to be done in person.
And I suppose two questions just in terms of this guidance that you had to wait for. How long did you have to wait for it, I suppose, first?
Well, those different elements came at different times. The working from home didn't probably come until the UK government gave the guidance for people to work at home. And so we were trying to socially distance in offices ahead of that. And then the guidance around staff who were able to continue at their work and other staff who were perhaps to work at home or advised to work at home. Again, that took a number of weeks as well. And then the guidance about the visits was probably from memory, was maybe our latest bit. So all of it was probably delivered in a matter of weeks, but the staff wanted answers immediately.
In that period where the guidance hadn't been delivered, as you identify, a matter of weeks, did that, I know that you've told us earlier it was business as usual, essentially in the absence of the guidance, were health visitors just doing what they'd done pre-pandemic?
They were expected to, but people were very anxious about that, and people started to feel very stressed around what they were perhaps walking into, what they might, people were very worried about contracting COVID, and they were very worried about, I remember being, why am I sitting in this office? Why am I being made to come into work this morning when I could do this same paperwork at home? And then people asking about, I have X condition, does that mean I can work at home more? Or, so people got very anxious. They got anxious about taking COVID into families and infecting families and new babies, and they were worried about bringing COVID back to their own families.
Staying on the guidance point, at paragraph 36, you talk about when guidance was issued, that it think you say it went to senior management meeting almost on a daily basis to discuss the updates, and the guidance would essentially cascade down through various layers of management. Am I correct in my understanding of your statement that the guidance was regularly changing?
I don't think it was regularly changing. There was some other iterations, as far as I remember. So we might have had 2 or 3 versions over time. I suppose I would probably say it was more. It got more developed.
I suppose my question, if I put it, I suppose quite bluntly, was the guidance clear? I suppose I'm asking you in a binary question. I suppose. Was some of the guidance unclear and some of it clear?
I would say there's a potential for that, yes, I think.
Moving on, in your statement, you talk of the impact of the delivery of services as a result of the COVID-19 pandemic. We've already discussed working at home, and you identify that you worked in a geographic area, this is at paragraph 38, where the parents were professionals and therefore you had less concerns about digital poverty. Is the contrary true, that if you'd been working in a poorer area, would you have concerns about digital poverty?
Yes, I think that was already known, and then there was a scheme to offer technology for families that needed it. So my understanding is we know that children who were the ones that probably needed to be in school the most were the children who were not present in school and weren't present online. And we did start to deliver. Health Visitors were out delivering iPads and SIM cards in order for children to be able to access or families to be able to access these kind of educational materials.
And was that, do you know where the funding for that, was that a Scottish Government initiative, was it Health Board?
I think it was a Scottish Government initiative that was then, it came via a different team, and they were coordinating it, but the Health Visitors, as visitors to a home anyway, were delivering. They were to identify the families who would need it and then distribute them.
Paragraph 39 of your statement, you discuss the infant feeding service. Can you tell me what is that service?
The infant feeding service, there's a variety of things, but we know that breastfeeding rates across Scotland are pretty poor, and often there's a lack of real support in order to establish and maintain breastfeeding. So there's a range of services. The Health Visitor, of course, provides a universal provision around that and supports infant feeding, and there is also then sort of a specialist service if there's what we call a problem-solving clinic. And there's also then usually community groups that would offer sort of peer support for breastfeeding that Health Visitors may or may not sort of attend, as well as charitable third sector sort of organisations. And
just the infant feeding service, so am I correct that is it simply breastfeeding, or is it other types of feeding?
It can be other issues with feeding, but a lot of the problem-solving things come around breastfeeding.
Okay. Now, you say in your statement that this service has really struggled to come back post-pandemic. Can you explain what is it about the pandemic that's caused that to struggle to come back?
Well, I think, again, post-pandemic, people looked at what they were doing in terms of services and how they would deliver them in a different way. The problem-solving clinic, I think, had some success in doing remote contact with families and still were able to support. But there were other things that perhaps didn't come back in the same way. We used to support, Health Visitors used to support at what we called weaning fairs, where there was information around progressing on to solid foods, and there would be a number of speakers at those events for parents. That took a long time for those to come back. They're only sort of coming back in the last maybe year or so. The infant feeding groups, again, similarly in the community, they've taken a long time to sort of come back to face-to-face. And sorry, there was something else I was going to say about the infant feeding team that I can't.
Don't worry about it.
Sorry.
Paragraph, no, that's quite all right. In paragraph 43, you mentioned that health visitors were not able to put their children into childcare hubs. Was that anything that was ever raised at I don't know, either a senior management level or higher?
Certainly, any issues I would have in the team, I would certainly raise with my service manager, and I assume that she was taking that back to the senior team. It was generally children that, if they were under the age of sort of nursery or school age, where they had perhaps informal childcare at the time before the pandemic, like their own parents, grandparents watching their children, and they didn't then qualify for that provision, those childcare hubs. And at the very beginning of the pandemic, there was no childcare bubbles had been created. So health visitors, although they could work at home doing their documentation, they, if they had young children, they were telling me that they didn't know what their priorities were. They were looking at a screen all day, and their own children they felt were not necessarily getting the same level of supervision that they should have had.
But if I understand you correctly, it wasn't just simply looking at a screen all day. There was this business as usual period where health visitors were expected to go out, but nonetheless no longer had the childcare that they could rely upon. Were health visitors essentially phoning in saying, what do I do?
Yes, there was some of that, and we again had to try and do a bit of local support around that, sort of individual support, where perhaps they would maybe have a particular day where they did have, for example, a partner at home that was able to watch it, and they would do as many visits as they could on that one day, and then so we tried to be very open and flexible about ways of working. They
presumably couldn't take children to the health visits, no?
No.
Moving on to the impact of the COVID-19 pandemic on children section of your statement, which starts at paragraph 49. You tell us at paragraph 50 that children, they weren't going to nursery during the pandemic, which meant that they didn't get used to, firstly, socialising with other children, and secondly, getting used to being away from parents. I'm just interested in how that affects the development of young children. Does that delay development, or is that a permanent loss that will stay with them throughout their life?
I think it's difficult to say it would be permanent, because we know so much about brain development and the plasticity of the brain and the ability to develop those skills later that you've maybe not learned earlier. I suppose the question about did that delay their development would have been around it would depend on their experiences at home out with nursery. So if you were in a very, rich environment at home, then you would benefit from that. But if you are a child whose parents are, working and focused on that, then there's a likelihood that you've not had the same sort of stimulation and support as a young child that you would normally have got if you're in nursery.
And this isn't in your statement, but have you noticed a difference where children had siblings as opposed to someone else to play with, for want of a better term? So
it's difficult for me because I'm now in family nurse partnership, and we deal with the oldest child to 2. So some of the developmental things you might see are probably, I'm probably not seeing that because I'm not in that age range now.
Well, that's quite candid of you, and a fair answer. Moving on to the child's health, but you discuss the child smile service and oral health support at paragraph 51, and you offer your opinion that you think we'll see an increase in young children with tooth decay. I'm just wondering again, is that something that is going to be a temporary, or is that something that will have long-lasting effects?
It can have long-lasting effects. There is definite issues with losing your teeth. Your teeth are responsible for you making sounds and your correct speech.
But are these not baby teeth we're talking about? I'm just wondering, are they? I'm just wondering whether, sorry, I put my question in a different way. I suppose I'm wondering if a lack of installing a sense of oral health into a child has lasting consequences? I suppose that's, and I don't want to lead
Yes.
you, but I suppose that's the question that I had in my mind. I've got young
Yes.
children, and I know how difficult, and you have to buy toothbrushes with firemen or animals and so forth on it to encourage them and such like. And I'm just wondering if in some way the lack of those services somehow had an effect.
Yes, I mean, and my apologies for laughing. I suppose what I was thinking about was the reasons child smell came in was because we had a culture of baby teeth didn't matter because they fell out anyway, and we took a long time over child smell to change that opinion, that actually your baby teeth are important for your alignment of your adult teeth coming in, for your ability to make sounds and communicate effectively, for your confidence with a smile. So there are lots of reasons why that oral health is important. And I mean, my understanding is one of the highest reasons for general anaesthetic in the under fives is for dental decay and clearance of those teeth, the pain that comes with that decay as well. And potentially we set up what happened years ago. We set up adults who are frightened of the dentist because the only time they go is when they're in pain. So we create more fear of the dentist and less provision and less prevention of preventing those things happening in generation upon generation upon generation.
And presumably...
I suppose I'm in dangerous territory here, I've got to admit, but I suppose that if there is an impairment of a child's ability to speak properly or speak at the appropriate level caused by dental problems at that earlier age, that effect can be long-standing because damage done to a child's ability to speak in its earliest years could be carried forward. Is that a fair comment?
I think that is a fair comment, my lord. Again, the ability to make friendships as a young child in nursery, when you're able to communicate effectively, when you're confident in those abilities to make friends and sustain friends. So there is probably wider effects than the issue alone of dental decay.
See that, yeah, thanks.
Thank you, Lord. And moving on to, you deal with PPE starting at paragraph 53, and you tell us that in the early stages of the pandemic, health visitors were told they didn't need to wear any PPE. Where was that advice coming from?
I think that must have been coming, as I said, the senior management. My understanding was senior management team were meeting on a very regular basis, perhaps even daily, and they had links in, or people within that senior management team had links into government, and I take it Public Health Scotland, and this is where our information was coming from in terms of guided about PPE. So initially we were told that as long as we maintained a 2 metre distance, and then later, I think, again, there was a bit information later about the length of time that you were in a house. If you were in, less than an hour, was it, something like that, and maintained a 2 metre distance, or you would be okay. Again, people obviously had some ideas about how they thought COVID was spreading, and this was the information they had, and this was the information they were sharing. And we were then to cascade that down into how that worked into practice.
In terms of, so that's at the early stages, the guidance was that you didn't require to wear a mask. You tell us at paragraph 58 that, and I think quotes, eventually guidance came in stating that health visitors needed to wear a mask, gloves and an apron. Just to kind of put I suppose to try and put it into, and I appreciate I'm asking you to think back a few years, but by eventually, again, was that a matter of weeks? Was that a matter of months?
It would be a matter of weeks again, I think.
And when that guidance was issued that you were required to wear a mask, gloves and an apron, can you remember what type of mask you were advised to wear? We
were asked to wear, or we were told that a fluid-resistant surgical mask would be all that was required. And again, our guidance, I don't think, was specific to health visitors. From memory, the guidance was about community staff, and therefore there was a sort of level of, this is kind of the level of PPE that is required. So there was face masks, gloves and aprons, and then there was an option of a face shield, a visor, if people felt that that's what they also wanted.
When, in terms of PPE, you identify in your statement that, I think you say that gloves ripped and the apron ties were breaking, I suppose, and you've identified what type of masks. Do you have a view on whether or not the PPE that was being supplied was adequate?
I think it depended on what came in the order. So sometimes we ordered and nothing, we didn't get because there wasn't any.
I'm just thinking when you did get, so if you got a mask, was it, did you, if I say FFP3 masks, do you know the kind of respiratory type mask, did you ever get provided with those type of masks?
No.
So it was always the kind of, I'll call it the blue.
Yes,
I think some
surgical
people,
mask.
I was going to say a lot of people refer to them as surgical masks.
Yes.
That, in terms of when PPE did arrive, were you satisfied, well, this is fit for purpose, this is adequate, or did you have concerns?
I think certainly there was the concerns if the gloves were ripping, and again, it was variable. Some rolls of aprons, for example, were perfectly adequate. They had the loop for your head and tied around your waist. I've given in my statement about the roll I had, and clearly they were manufactured faulty, and there was I think 2 tires, that one was where the neck loop should be and one was where the waist one would be, and I was trying to tie them sort of together on a very windy day outside somebody's house. So it was variable. I think staff felt that, what makes the difference between me having a gown, an apron on at the front, but sitting on somebody's couch without anything covering me at the back. There was and the gloves, I think, were variable. Some gloves we got, staff were, happy with. Others, they felt that they were, they were easily ripped, or they just didn't do the job that they needed them to do.
Can I pick you up on a point? You said when it did arrive.
Yes.
Are you suggesting that sometimes there wasn't any PPE, that the stocks had run out?
Yes, or certainly perhaps they went to places that were deemed to be more priority. As I said, we did have some ability, depending on the kind of visit we were doing, we had the ability to postpone that visit. So we were not, and we also could screen, and if there was COVID in the house, we could say, I'll not come today, I'll make it, next week. So we did have that. That ability. So I don't know whether sometimes PPE went to other services that were in greater need of it, but sometimes the ordering was done, and sometimes when the order came the following week, sometimes you had everything that you asked for, and other times not everything was there.
Okay, so there could be shortages.
Yes.
Shortly. Moving on in your paragraph 2, you talk about volunteering at the staff hub, and it's at paragraphs 66 to 71 of your statement, and you say that you're a volunteer in the staff wellbeing hub at Inverclyde Hospital. Can you firstly tell us what is a staff wellbeing hub?
I suppose if I was being very blunt, I would say it was the kind of things that used to perhaps be round and about in place before budgets got cut and everything got stopped. It may resemble, if you like, a doctor's mess, or a decent staff room.
If we don't, and I don't, if we didn't know what existed before then, can you give us a concrete example of what we would expect if we went into a wellbeing hub?
The wellbeing hubs were put in place to support staff in the hospital settings, and they provided a place for the staff to go and, in effect, be able to debrief. But they also provided, a lot of them provided a bed, for example, where staff, if they were working a long shift, could go and have a lie down during some breaks. There was, some of the local businesses supplied sort of meals, and they also, we were able to supply tea and coffee and, biscuits and snacks. And as I said, there was also they often were created in places that were wards that were maybe not in use, and so there was beds to be able to have a lie down. There was a shower facility. There was just things that take care of staff that we've seen eroded over, the last decade or so.
And Were there those types of hubs in all the hospitals, or do you know?
I'm not entirely sure. Certainly, I think they tried to put them in the main ones, and certainly I did the training day around that was, I think, sort of the Easter Monday of 2020. So that was the April time, or kind of towards the end of April, I think, that year maybe. And then it started up a couple of weeks later, which is why in my statement I've said that some of the staff that came down said, actually, we needed this a few weeks ago.
Well, I noted that in your statement you seem to be very supportive of these hubs, and you say that the hubs came too late and should have been earlier. Could they have been commenced earlier?
Well, I think you could say the same about all sorts of things, and I know the pandemic was obviously a bit of a moving feast, but if you've got a level of planning around these things, then I suppose that might be something that you would, if there was pre-planning, you would think that these things could be part of that, and therefore maybe the implementation wouldn't take as long as what we seem to have found during this pandemic. I think if we're learning lessons, it's about pre-planning and thinking about what things were put in place during COVID that would have been supportive and helpful, and actually have those ready so that if we go into a pandemic again, we know what will support staff to be able to do their jobs well.
Which would include wellbeing hubs, I think. Is that
could very possibly. I mean, it would be lovely to think that, especially because people are feeling that the work is so pressured and so difficult, that it would be good if these kind of things were put in place and kept in place. But as I said, these are the types of things that have been eroded over time.
You talk about the delivery of training in your statement at paragraph 72 to 75, and you explain that the impact of the pandemic on training health visitors, and you identify there's been a lack of in-person training and working remotely rather than alongside an experienced health visitor. Is there something that could have been done differently if this was to happen again in the future?
I think that's difficult to know, because you'd have to balance up the benefits of that learning and the need to learn alongside someone, with individual staff's fears and worries about what the spread of a virus would do if you were working alongside. It's a difficult balance, I think, to try and get right.
Maybe it's a question, I suppose, that I've asked previously, but the impact on the training, is that something that trainee health visitors, I'm sorry if that's not the term that you called it, that is the term, is that something that they will eventually develop and they'll get back to the level they would have been, or is this going to be a permanent drag on the profession?
I would hope it's not going to be a permanent drag. I mean, we're back now. We would be offering, well, we're not back in the offices in the same way that we used to be. However, I think we recognise now, if you have somebody in training, that you do need to spend more time with them than perhaps was possible during the pandemic. We obviously have things like the bases are open and available now, whereas in the height of the pandemic, bases were shut and people were maybe only allowed to go in on a rota basis, or at very sort of fixed points. So I think there is recognition about the need. I think for the individual health visitors, what we seem to be seeing is concerns about their competency as they become qualified health visitors, and I think it's that ability. It's the difficulty of quantifying tacit learning, the things you learn when you're sitting alongside somebody, and the difficulty is these staff are now facing, if you like, punitive policies in the workplace, perhaps because of their experiences during the pandemic.
Sorry, and I don't want to dwell on it, but when you say punitive policies,
capability,
all right,
disability, disciplinary, those kind of things. The notion that actually your competency is is considered to be compromised, and it may well be it's because of the limitations of the learning that they had.
It may not
Mr.
be.
Dunlop, you're into your last 10 minutes.
Yes, yes, Millard. I'm literally just on lessons to be learnt, so I shall only 5 minutes. Thank you, Millard. I was simply going to say that may be something that applies to more than simply the health visitors profession.
Absolutely.
In terms of, we go into the lessons to be learnt at paragraphs 76 to 78, and you identify that that includes better pandemic planning, and you quite fairly refer to the visiting of care homes, albeit that that's probably not directly within health visitors' role.
No.
We have your statement in front of you. Before thanking you for your time, is there anything else that you think that would be relevant for the inquiry that we haven't either discussed today, isn't within your statement, or has cropped up in your mind perhaps in the days running up to giving evidence?
I think I would probably say, and it does go back to the point, Mr. Dunlop, that we made about that continuity, and health visiting is, they would say it's a therapeutic role rather than a clinical role. And I would say a therapeutic relationship's about, it's not just about the continuity, but it is about the ability to be emotionally available and provide emotional support and practical assistance to families when they need it. And what we found during the pandemic, that was disrupted, and since the pandemic, it seems to be almost, it feels impossible to deliver. And some of that's because we're not funding health visitors the way we need to. We have an aspiration in Scotland that Scotland will be the best place to grow up, and I'm not seeing the evidence of that happening. I'm seeing a decline in those things happening. We hear about cost of living crisis, we hear about fuel poverty and food poverty, and health visitors are one of the first people around these families and are able to provide some support, but we can only do that if we've got the resource to be able to do that. And ultimately we have, in order to be able to support children, to support their early experiences and to provide rich experiences for them as parents, you've got to feel emotionally present and available to your child. And if you're not feeling that, then it's very difficult to provide your children with these optimum experiences. Health visitors should try to do that for parents, and health visitors also need to feel that. And when we're sitting, as we currently are, with the staffing pressures that we've got and have had since 2021, people are exhausted, they're tired, and they're not able to emotionally contain and support other people.
Thank you. And thank you for your time, and also the time that you've obviously put into preparing your comprehensive statement, which is very helpful. Well, I have no further questions.
Very good. Thank you, Mr. Dunlop. Thank you, Mrs. Holliday. Appreciate that. We'll come back at 20 to 11 for the next witness. Thank you very much. Now, good morning, Ms. Barami.
Good morning, my lord. Our next witness is Claire Elizabeth Ronald of the Chartered Society of Physiotherapists, and her witness statement reference for the record is SCI WT 0184-501.
Thank you. Good morning, Ms. Ronald.
Good morning.
Very good. Are you ready, Ms. Barami?
Yes, my lord, thank you.
On you go. Thank you.
Thank you. Good morning, Ms. Ronald. Please could you start off by telling us about your role within the Chartered Society of Physiotherapists and also a brief background about the society?
Thanks. It's the Chartered Society of Physiotherapy rather than physiotherapists.
Sorry.
It's slightly pedantic, but so the Chartered Society of Physiotherapy is the professional body and trade union for physiotherapists and physiotherapy support workers. We also cover students and retired members and have some overseas members as well in sort of different categories. My role is working for the trade union part of the CSP, and I cover Scotland along with someone else and also cover Northern Ireland as the other half of my job.
Thank you. And you're a senior negotiating officer within the organisation?
Yeah, that's the job title, yeah.
Yes. But your background is that you are a qualified physiotherapist.
I was. I'm no longer on the HCPC register, so I can't technically call myself a physiotherapist anymore. But yeah, I was a physiotherapist.
Yes, you're experienced in that field.
Yeah.
Thank you. Could you tell us a bit about the areas in which physiotherapists work?
Physiotherapists can be found in so many areas. So within the health service, physios will be on most wards. So we'll be on the surgical wards, orthopaedic wards, medical wards. We work with people from birth right through. So we're in neonatal units. We're dealing antenatally, postnatally with mums. You'll have physios in independent hospitals, physios in the private sector, in charities dealing with hospice care as well, right through to your kind of elite sports clubs and elite sports people. So it's a whole breadth of areas that physiotherapy works within.
Thank you. And one area I think that was of particular significance during the pandemic was respiratory care.
Yeah.
Could you tell us what the significance of physiotherapist involvement in respiratory care was for ensuring that patients survive the impacts of COVID?
Yeah, physio is part of the multidisciplinary team in both intensive care units and kind of acute medical wards. So dealing with patients with respiratory problems, trying to increase their airflow, clearing of secretions when they're there. So using manual therapy techniques, breathing techniques, and during COVID, in the kind of early stages, what became quite apparent was putting patients into a prone position, so lying on their front improved their ventilation because it opened up more of their kind of lung space at the back. So they were involved in kind of proning teams as well as on the ICU and on the acute medical wards.
And presumably that then requires the physiotherapist to work very closely, physically closely with patients, and if they are putting patients into a prone position, then especially for adults, they wouldn't be able to do that alone often.
No, that involved kind of, so the proning involved working as teams, so being able to coordinate getting the patient into position in a safe way, both for the patient and for the staff involved. So yeah, it was close working with other staff and with patients who were COVID positive.
Thank you. And when the lockdown restrictions were announced, what was the initial impact on your members, especially given that their work necessarily involves being so close to others?
So when lockdown initially impacted within the NHS, some of our clients would have been classed as extremely vulnerable and so shielding, so services were pulled back from those areas and only going in within emergency sort of
situation. So a lot of our staff in the hospital were redeployed, still within physiotherapy, but more into the acute side, so into where patients still were. So your acute medical ward, your ICU, your high dependency units, so pulled into those areas. For our members in education, there was a big impact, and then for our members in the private sector and in independent hospitals, again, a really big impact on what they were allowed to see and what was defined as an emergency. So if you were running your own clinic as a private physiotherapist, what were you allowed to see within those lockdown restrictions? So a lot of clinics were essentially closed, but not technically closed at that time.
And was there a fear of potentially taking the virus home?
I think physiotherapists, along with anyone who was working in the acute hospital, had that real fear. This was a virus that we didn't know an awful lot about. The guidance seemed to be constantly changing and evolving. If you're working really closely, like in physical contact with patients who are COVID positive, there's a natural fear and anxiety, and especially if you've come from an area where you previously were out in the community, possibly working with children or people with learning disabilities, mental health, and then moved in to working with acute respiratory conditions, there was a greater level of anxiety.
Where staff were redeployed to other physiotherapy roles, but in a different setting in ICU or acute wards, how did they adjust to that change in their daily requirements of their job, and what was the effect on staff morale?
How staff adjusted is probably as unique as each staff member. So there was, in most areas, you would have been looking at the skill set people had and moving them within their skill set. So taking our more respiratory experienced people and moving them, and then backfilling some of those roles with other physiotherapists. It was, anxieties were high, even the staff who were managing the teams. A lot of teams were then adjusting their hours to cover longer periods in the hospital. You also have the problem that you're working in the hospital, but if you have children, who's then looking after your children at that point in time? We have quite a high female population in physiotherapy, and again, caring still tends to fall to the women in the household. So there's that anxiety of where are you leaving your children, and then what are you bringing back to children? So I think, like other health professionals, lots of the same stories at the outset of virtually stripping off outside the house, the fear of are you washing your uniform in with your other clothes, and not knowing exactly how the virus was spread at the outset.
Thank you. And I think some physiotherapists were redeployed to roles out with physiotherapy, is that correct?
Yeah, so some of them would have been redeployed into vaccination services or into supporting other parts of the hospital, but it was less so for physio. More of them were redeployed. I think in one of the meetings we had with members, about 80% had been redeployed within physiotherapy rather than outside of physiotherapy.
For those who were redeployed outside, were they provided with training, and did they feel adequately supported to be taking on those new roles?
In most cases, yeah, training was provided. You wouldn't just dump somebody into a vaccination clinic, so there was training and there was upskilling to put people into those roles. How comfortable and how confident, again, if you ask 10 different people, you're going to get 10 different answers, even with the same sort of level of training, because everyone has their own background concerns and their own skill set that they're bringing into it.
Sure. And do you know whether there was a difference in morale between those who were redeployed within physiotherapy roles and those out with physiotherapy roles? Or is that not something that's been looked into?
I can double check whether we covered that in any of our surveys, but I don't have that information to hand.
Thank you. Now, those who were redeployed to ICU and acute wards, presumably there would have been an increase in workload, but also an increase in the number of patients with terminal conditions or who did pass away during the pandemic. What was the impact of that on your staff? Because it's not a profession that one would usually associate with high numbers of deaths.
Yeah.
How did staff find that?
I think we're still seeing the knock-on effects of that as people are still recovering from what happened during COVID, from the redeployment. I think when you're in it at the time, you just kind of buckle down and deal with what's there. The health services have been really good at putting in a variety of supports and health and wellbeing initiatives. What's not always so clear is how well they're being audited. On uptake. Is that uptake equal across the professions? Is it easy for different professions to access? And I think as well, when you had social distancing in place, where you would normally bounce ideas off another therapist or offload onto a colleague when you're not seeing your colleagues in the same way, then that has an impact on your mental health and well-being. And even at the time, if you were going off on maternity leave, you didn't have your usual chance to say goodbye or talk to people before you were going off, staff who retired or who changed jobs in that time. Just kind of, you might have had an outdoor gathering if the weather, which in Scotland isn't always ideal, allowed for it. So you lost some of that connection that staff might have had. And I think that's still having an impact.
Thank you. Now, where therapists had been redeployed, obviously there were patients who were then no longer receiving physiotherapy treatment or physiotherapy. Do your members think that much thought had been given to those patients whose health necessitated physiotherapy, but whose therapists were redeployed?
I think where a lot of the patients would have been in the shielding category, and so naturally you were trying to restrict the amount of people that went in, and I think the decisions that were made with the best of intentions at that time, but I think it's how we learn from them going forward into what would constitute essential for somebody who's in a shielding category. And I know from conversations with some staff in those areas that when they've gone back to their service post-COVID, they're seeing patients who will not regain where their potential was pre-COVID. And there's a lot of guilt associated with that for staff, that have they in some way let their clients down, that they know they're not going to get to quite where they should have been. And I think we need to consider, if there is any future pandemic, how we look after shielded patients, but also consider their rehabilitation needs, and maintaining that rehabilitation, their mobility, their function, their posture, all of those elements do require some input.
Yeah. Do you think then that despite having the best of intentions, perhaps those responsible for formulating the policy haven't had a full appreciation of how vital physiotherapy is to some patients and their ability to function generally? You know, I know that as you've told us, physiotherapists can help with breathing, for example, and there are people living in the community who do have respiratory issues or movement issues, and so that therapy plays a role in enhancing their everyday life for them to do basic things. So do you think perhaps there was a lack of that fundamental appreciation of the role of physiotherapy?
Yeah, I think there was a lack of understanding of the impact of withdrawing that service. And I think it's understanding that while some patients are vulnerable and might need to shield from the virus, you still have to encourage their mobility, improve their function if you want to maintain that quality
Yes.
of life. And even for patients coming out of hospital post-COVID, again, there is that need to continue that rehabilitation to maximise their function and their ability, so that they can maintain as active a part in life as possible.
Yes. And now that things have largely gone back to normal, or by the end of 2022, which is the time period we were looking at, were any extra resources put in place to help those patients try to get to a similar level that they would have been, even if they couldn't fully catch up?
In terms of workforce planning, I don't think we've seen an increase in the resource for those areas. We've seen the staff who were redeployed back within those areas, but not necessarily an extra resource put in. And I think for the staff, there's an anxiety that, are they seen as non-essential services? So is there a risk of them being pulled again? What happens if we're short-staffed, short-funded? Which areas are going to be pulled and which areas are going to suffer? And is it always the acute hospitals that are seen as the mainstay, instead of looking at how we facilitate patients' journeys and that rehabilitation pathway? So it's how we can think about it differently.
Yeah. And so is that then continuing to have an impact on staff morale and mental health?
Yeah, I think that's something we're still seeing, and I think I mentioned in the report that we're anecdotally hearing of more staff retiring sooner than they might have pre-COVID. In the old pension scheme, physiotherapists had a right to retire at 55 without an actuarial kind of reduction, so special class status. And I think we're seeing more people who are approaching that threshold, taking that up, where they might have worked a little bit longer in the past.
Do you think that's largely down to morale, or do you think there are other issues that affect that?
I think, again, there's many issues that affect it. I think COVID caused many of us to reevaluate the decisions we make in life, to reevaluate your work-life balance, to look at things. But morale and mental health and well-being certainly contributes into that picture as well.
Thank you. Now, you mentioned in your, I want to move on to PPE. Could you tell us about the issues that your members had with PPE?
One of the issues that was probably more unique to physio with PPE was around about how you defined an aerosol generating procedure. Say physio works quite closely in respiratory care, so you're encouraging patients to take deep breaths, you're encouraging them to cough, and you're often quite close to them at that point of view. You know, if you've got your hands on somebody's chest, encouraging that sort of chest expansion, you can't do that from really far away.
Yes.
And so physios are aware that when patients cough, it generates aerosols that quite often land on you. But there was a big debate about whether chest physiotherapy was classed as an aerosol generating procedure and therefore should get a higher level of PPE than just a kind of surgical mask, so more your FFP3 type masks or your fit tested masks. And that caused a lot of concern at the beginning for us, and the lack of ability for our professional body to be involved in the IPC, the Infection Prevention Control Cell discussions around about that. So we were advising members that they needed to risk assess, but that then could put them in conflict with other staff, or you had staff going, why are physios wearing a mask in with that patient and we are not allowed to wear a mask?
Yes.
And then you have the common issues lots of other areas have. PPE predominantly is designed around a male body, even though our workforce in the NHS is not predominantly male. So you had the issues of the fit test and how well the mask's fitted when you have a smaller face than what the mask has been designed for. So you had staff who might only have one or two brands of masks that they passed the fit test on, and they were in short supply, so that had an impact. And then the sort of common issues just around, again, length of apron. Are the gloves in the right size for the type of staff that are in? So do you have more large gloves, but more staff who need small gloves for the work they're doing?
Yes, thank you. And I think there were also issues around the disposal of PPE for those based in the community. Is that right?
Yeah, so it was trying to get clarity and understanding on how you disposed of it. Did it get disposed of in the person's household waste? Did it sit outside their house for so many days and then get put into their household waste? Did you bring it back to the centre? And if people were using their own car, there's that question of, do I really want used PPE sitting in the back of the car where my kids are going to be sitting, or where I'm transporting our shopping back home? Do you want to put your shopping bags next to where you've just been carrying contaminated PPE back? Yes. And especially with Scottish weather, staff are being encouraged to put PPE on before they get into the house. So you were often putting it on in your car, which is not right outside people's houses. It's very rare that you can park right outside somebody's house, so you're often then having to run through the rain, run through the snow, and you've got to be bare to the elbows, so you're wearing just a uniform and an apron and having to kind of run into houses, and then again coming out and having to change outside and run back to the car. That all has an impact on general health and well-being if you're getting soaked on your way to a client.
Yes. Did the rules require physiotherapists to be bare below the elbows?
It's kind of, for hand washing, it tends to be bare below the elbows. Okay. So you couldn't put a fleece on and comply with infection control guidance. Okay.
Did you try to contact anyone to get clarity around the issue of PPE disposal?
The society, not me personally, but within the CSP, yeah, it was, and again, it's trying to figure out, is the unique situation here is it UK guidance that applies in Scotland, or do we have different guidance in Scotland? So you're often kind of rejigging and re-looking at where that guidance is and where it comes from. Within the hospitals, for shortages of PPE, they did quite quickly set up a PPE helpline, which was really useful because we could then direct staff to that, so we weren't having to act as an intermediary and try and interpret what their concerns were. They were able to go direct with their concerns.
Yes, thank you. And with the National Infection Prevention and Control, you said that the society wasn't included within those conversations and the consultation. Did you approach them with a view to being involved? And if you did, or the society did, what was the response?
That was done at a UK level, and I can double check for you the communication, but I do know that there was certainly requests to be involved on the IPC discussions, and especially around about aerosol generating procedures, and there was quite a lot of communication back and forwards about that, and I can share that with you.
You mentioned in your statement that you felt more involved with what was going on in Northern Ireland. Why was that the case, that they were willing to include the society?
I think within Northern Ireland, I hold a seat for 5 unions on our joint negotiating forum, so when we were having fortnightly meetings, I was naturally included and then cascading the information back out. Where in Scotland, we discovered about groups that were happening, but that we weren't aware of until quite a while afterwards, that weren't our usual structures that were, and they were put in place because decisions needed to be made at pace, but it's really hard when you're seeing the outcome of the decisions but not knowing where they're made, and you're working at pace as well, but then having to go, wait a minute, what's this group that I haven't heard about? How do I find out about it? How do I know where it's meeting, what the minutes of the group are? So it took a while to understand where the gap was, to then know where to approach.
Yes. And once you approached them, were you able to join those groups?
So the group in Scotland, the Senior Leadership Workforce Group, I think it was called, we weren't able to join it, but my staff side colleagues who were on it were able to share the minutes from the meeting with you. So you at least had some understanding of what was happening. But it wasn't quite the same as being engaged and involved.
Yes, I mean, this will be an obvious question, but presumably you would have found it more beneficial to be included and be able to input into the decisions that were made?
Even to be able to understand what was leading to the decisions, you know, so to know the conversation that's then led to that being the decision, instead of kind of going, I see the decision, but I don't know how we arrived at that. So yeah, an earlier involvement would have been ideal, and I think that would be one of the key learnings for us from this.
Thank you. Now, going back to the issue of early retirement, is this having a knock-on consequence on current workforce levels and recruitment, or are you finding that graduates are filling the vacancies at a good pace?
Within Scotland, the CSP has a campaign around about Scotland needs more physiotherapists. Our undergraduate training places haven't increased for a considerable period of time, so we don't think that we're going to be producing enough physiotherapists to meet the demand that is out there, even within the existing gaps within the workforce. We think there's going to be problems.
Sure. Thank you. And I want to come on to students and training in a moment, but just before we move on to that, you mention in your statement at paragraphs 40 and 41 that there's been a loss of rehabilitation space, that spaces such as gyms and hydrotherapy pools were repurposed and have not returned.
Yeah.
For what purposes are they being used?
So physiotherapy gyms are normally quite big spaces, and at the start of lockdown we weren't bringing patients in. There was a large move to doing some of our MSK outpatient services through near me appointments, so using video conferencing. So at that time it made sense for some of those spaces to be repurposed, sometimes for storage, sometimes for a variety of reasons. On a number of acute wards, so on medical wards or on stroke wards, we might have had a bay set aside as a rehab space, and some of them have been repurposed, beds have been put in them. That then limits how easily physiotherapy can do rehabilitation for stroke patients, and for other sort of neurological conditions and orthopaedic conditions. If you don't have space, you're then trying to do rehab at a bed space, which is not always easy to fit a number of therapists in and a patient, and to maintain dignity. And if you need to bring equipment in, that makes it even more awkward. You can't always take patients down to the main physio gym because simply transporting them isn't always easy, and for some patients it can be too loud, too noisy, too distracting, and you need somewhere quieter to allow you to do that one-to-one rehab. So it is having a knock-on effect, and it's something that we're still trying to encourage physiotherapists to challenge getting those spaces back, but it's not always easy. And not all of our hydrotherapy pools have reopened, so again, that's an area of rehabilitation that's not open to all patients in all areas of Scotland.
Why have the hydrotherapy pools remained closed? Presumably there aren't many other purposes that those spaces can serve.
No, part of the problem is that once you've emptied a hydrotherapy pool, and if it remains empty for a while, there can be structural issues. So there's some issues around about that, and some issues around about, from my understanding, some of it is a reluctance of the cost. These are heated pools, so there is a cost associated with that. You have to have them at or close to body temperature for the rehabilitation. So there's a reluctance to invest in that cost. But that also has a cost in that you're then not able to use that as a tool for patients, and you're having to find alternative alternative ways to do therapy where hydrotherapy might have been the easier approach.
Yeah. And is that having both the lack of hydrotherapy pools and the lack of physiotherapy gyms, wards with physiotherapy spaces, is that having a significant impact on patient well-being and perhaps even the time spent in acute wards?
We would say yes. It's really hard to get it quantifiable as the data, but if you want to improve patient flow through a hospital, you need to look at how you're rehabilitating them.
Yes.
And you need to have that investment in rehabilitation and have it meaningful. You're not going to get patients out of hospital unless you improve their mobility, improve their function, and returning as much of that mobility and function as possible. Yeah. And that's where physiotherapy is key, and it's where our rehab spaces are also key. There's no point in having amazingly skilled physiotherapists who are trying to do a job at a bedside or trying to rehabilitate someone's balance on an airflow mattress that you're having to kneel behind them on. So as a therapist, you're not on a stable surface and you're trying to work with your patients instead of being able to take them to a gym and have a plinth that's adjustable, that's easy to use, and that works best for the patient and therapist.
Yeah. And so part of the reasoning you think is down to funding, saving money, but actually it might be costing just as much or more to keep these patients in hospital for longer, and it's also at the expense of quality of life for the patients. Thank you. So, I want to move on to students and training now, and this starts at paragraph 45 of your statement. Firstly, could you tell us at what stage of their training do physiotherapy students engage in placement-based learning?
In most universities, you do your first placements within the first year, so you are out on placements from very early on. And it's in supervision with your physiotherapist, with your qualified staff.
And how long are placements generally for? Is it, presumably it won't be a full year at a time, is it a few weeks, a few months? Are they at university and in hospitals or community?
Yeah, so a lot of the universities will have a split, so half the students out and half the students in. So you might have students in at lectures and then other students out on placements. Placements tend to be between a 6-week and a 12-week duration, so you're normally, depending on the speciality, so you're normally in the hospital working with the therapist for that kind of 6-week period of the placement.
And do students express a preference for certain settings, or is it a requirement that every student experiences particular settings?
From knowledge, the students don't get to kind of, there is key areas they should be covering and a key number of hours they have to cover clinically to get their qualification. So as well as their exams, their kind of practical placement experience also counts.
Yes. And what is the purpose, the primary purpose of placement-based learning?
There's a limit to what you can do either on other students who don't have that condition. So if you want to learn how to handle a stroke patient, how to rehabilitate somebody with Parkinson's, how to work with paediatric patients, you can't replicate that on a healthy student. You really need to be seeing what therapy is. It's a very, physiotherapy is and should be a very hands-on profession. So you do need to be on placement to learn how to do that. If you're wanting to deal with patients with COPD or chronic obstructive pulmonary disease, again, it's really hard to learn those techniques. On healthy people, you need to be in treating your patients and learning on the job.
Thank you. And you mentioned in your statement that apart from students who were in their final year, all other placements were cancelled. What was the impact on that of on the training of first to third year students?
The impact of that was huge. So we also had the fact that that their classes went online. So where you would have been in person before, when we brought back in person, it was in much smaller groups. There was social distancing, which becomes really hard with a hands-on profession to maintain social distancing. The focus correctly was on getting final year students to meet their requirement of clinical hours, knowing that with the earlier students there would be the time to kind of gain that back. Some of them were then doing placements virtually, so where we were doing near me consultations, the students could be in on them, not always in the same room as the physiotherapist, and then chatting to the physio afterwards about the consultation. I think, again, this is something we're still seeing the impact of. Students had a very altered experience during COVID, and that, I think, is still having an impact on their confidence as they come out, on their skills. And we are hearing anecdotally about slightly more time needing to be taken with new graduates who were students during this time, that it's almost making up for some of what they couldn't get during that pandemic period.
For those students, you mentioned that those earlier in their university career, it was thought that they could catch up. For those who were in first or second year in 2020, by the time they got to their final year, do you think that they were able to catch up, or do you think there was a noticeable difference between that cohort and those who had 4 years or 3 years of placement-based learning before that point?
In order to qualify, you have to do a set number of clinical hours. So they had all done the same amount of clinical hours. So they had to make those clinical hours up. The quality, I think we're still monitoring and seeing. I couldn't say for definite. I would probably need to speak to some of my HEI colleagues to get more information on how they've perceived it at this point in time as well.
And what impact has that had on their ability to qualify into the profession? You've mentioned that things are taking a bit more time. Do they have to carry on training once they graduate and start a position, or at the point of starting a position, are they able to just start without any other training?
I mean, when you qualify as a physiotherapist, you're an autonomous professional. But what I would say is your university degree gives you your baseline, and you are constantly learning. So even in your first job, it's almost a developmental post that you're still learning within that first post. And I think that's where we're still seeing some of the impacts, and then you have the knock-on effects if we're seeing retirements, if we're seeing an impact in our workforce, that there's less staff to supervise, so there's more stress generally all round, which is really where we need to look at that workforce planning in a more holistic way.
So are there then issues with retaining practical knowledge and skills? I would probably need to check that with some of my colleagues on our professional side on what they're hearing about that, and we can come back to you on that one. Thank you. Then moving on to paragraphs 46 and 47, I understand that you state the guidance was confusing, and we've heard that from others too, and that this had to do with the Four Nations approach or lack of it. On the basis that Scottish students or students in Scotland were presumably on placements in Scotland, could you tell us a bit more about why the Four Nations approach affected that? Why it perhaps wouldn't have seemed the case that only Scottish guidance would apply? In what way were the Four Nations guidance interacting that led to confusion?
So this was more around about guidance for there was a point where we were trying to bring those who were close to concluding their training onto the HCPC register and into the workforce sooner, and also looking at when students had their summer gap, how could they help out within the health service. So there was guidance around about how we could bring students from various years into the workforce. The 4 Chief Allied Health Professions Officers, as I understand it, were in close communication with each other, the same way as the Chief Medical Officer, Chief Nursing Officers were. But then any guidance they produced had to be specific to the country. So there was a lot of confusion because we were seeing some forms of guidance. In Northern Ireland, I was hearing about it being done one way. In Scotland, it was then, again, where was the guidance? Was it coming out too late for what we were seeing within the workforce? Did we need that same amount of students coming into the workforce? So it was joining up the guidance with the workforce planning, with what the service actually required, with whether it was meeting the students' needs and the service needs. And again, not always clear communication channels for us as a professional body at that point in time.
Thank you. And you mentioned that the CSP wasn't involved in decision making with the Scottish Government. Did the Society ever get a chance to make representations before decisions were made, or did that position carry on throughout?
So that was sort of specifically this senior workforce leadership group. I think I've got the title correct. So there's partnerships groups that existed pre-COVID and kind of were in place during COVID but not meeting to make the decisions. So Scottish Terms and Conditions Committee, it was more the Secretariat that were making decisions and sharing that with the rest of us. Scottish Workforce and Staff Governance wasn't really meeting, and the Scottish Partnership Forum wasn't really meeting. So the Senior Leadership Workforce Group was bringing, to my understanding, it was bringing some of health and social care together, because social care is not as involved in those other groups. And it was the one that was making decisions at pace and that we found out about at a much later stage. So we were never part of that group, but we did eventually manage to see the minutes from the group, so we're able to see the kind of scope of decision making and try and understand some of the decisions that were being made.
And then presumably following on from that, the Society didn't have a chance to make the impacts of decisions known to the Scottish Government. So, for example, the impact of not allowing placement-based learning and the like. Were you able to make any representations about that? Or? So
we were using the routes that were open to us. So to try and engage with the Chief Allied Health Professions Officer, it tended to be through a group called the Allied Health Professions Federation in Scotland. So that's where the professional bodies for the 14 allied health professions come together. So it was through that to make representation, through any direct communication routes we had. So we weren't sitting silent.
Yes.
We were trying to make our voice heard as much as possible.
What sort of response were you able to get?
Sometimes it felt like you were shouting into a void, that there wasn't always a clear response back, and you weren't hearing, right, we've heard from you on that, so we'll now include or involve. It didn't always open the communication channels that you would have hoped for from it, so you did then have to, again, use multiple means of trying to raise questions to try and figure out who was dealing with the decisions and how to get the answers.
And so following, so in terms of education, that was limited, and you didn't feel that you were being listened to. Overall, as an organisation, with the multiple different areas that you cover, how well do you think you were listened to by those making decisions? You mentioned in paragraph 59, for example, that you had fortnightly meetings with certain organisations and with civil servants. Do you think your concerns were listened to by the civil servants? Do you feel you were overall listened to?
The fortnightly meetings were in Northern Ireland.
Ah, okay.
So that was kind of the contrast for me,
yes.
was that as trade unions we were meeting regularly with our HR directors. Northern Ireland is smaller, we've got 5 trusts as opposed to 14 health boards, but it felt, from my point of view, that there was more desire to meet with us and talk. In Scotland, the problem was not really understanding where the decisions were being made, so not knowing who to speak to, so you were trying multiple routes to try and understand where decisions were being made and to try and have the concerns that our members were raising with us then heard at the appropriate levels.
Yes. But within Scotland, that unfortunately doesn't seem to have happened.
No, for me it felt much more disconnected, and for me it was having that comparison of, and often in Northern Ireland I was hearing about where we were getting guidance from the chief medical officer, and it was like, all right, so now I can find that in Scotland because I know what I'm looking for.
Yes.
But if you're not involved in the groups, you're kind of having to hunt various places to try and find where the most relevant guidance is, and as I say, understanding, is it UK-wide guidance, in which case that's fine, I can leave some of my other colleagues to find that, or do I need to find something that's specific within Scotland? And if it is UK, are we applying it in Scotland, or are we tweaking it and changing it slightly for the needs within Scotland? So you were always kind of on a slight hunt whenever you found anything to then search it back and check you were giving the right information to members.
Yeah. And did that have quite an impact on the morale and mental health of your members as well?
I would hope that the members didn't see that as much. I think it probably had more of an impact on us as a professional body, and for the team of staff who were engaged with that. I would genuinely hope that our members didn't see that as much as we were experiencing it.
So for the society itself, a key issue is that if there was to be another pandemic in future, that the society is involved in these decision-making processes, so as to avoid these long-term consequences that you've spoken about.
Yeah, and I think because we're both a professional body and a trade union, there's scope to involve us in multiple ways. So the trade union channels should have been open to us. And again, as a professional body, we should have routes in as well for those. So where we're talking about terms and conditions and how things are applying, and then when we're talking about professional issues around about aerosol generating procedures and PPE, it's having the right routes for that joint communication from us, and to feel that the voices of our members are then heard within those decisions.
Yes, thank you. Now, is there anything that we haven't discussed today that you would like to mention at this point or raise?
I think, and I mentioned at point 61 in the statement about lessons to be learned, and it comes back to that rehabilitation, that I think each health board needs to have somebody whose focus is on rehabilitation, and have that rehabilitation lead and a clear rehabilitation pathway established in each health board. And I think that would then help with that communication, because if that rehabilitation lead is picking up on the relevant people in that rehabilitation journey, which isn't just physiotherapy but does involve a lot of our other allied health professions, I think that would make a significant difference. Our voice is often further down the chain within health boards, because of where the allied health professions as a group sit, and then it's our voice within that grouping. So you're often labelled as allied health professions who sit under the chief nurse. So you're further and further away from that decision making. So I think it's looking at whose voices are heard within health boards and how that impacts on the patient journey.
Thank you very much.
Yes, thank you, Miss Ronald. Miss Ronald, I beg your pardon.
Thank you.
Very good. Right, those are all the witnesses, I think, for today, Ms. Varami, and we're sitting again tomorrow morning at 9:30.
Thank you, my lord.
Thank you. That's all.